What I'd like to do today, I think, is in contrast to some of the great achievements I think we've been able to do with a number of our vaccines, particularly in the paediatric sphere, I think generally flu vaccine's lagging behind. And it is a vaccine that is recommended for a number of different populations. It's not the world's greatest vaccine. I think that's part of the reason it's perhaps not used as much as it should be, because it's a very safe vaccine, but we often don't think about it. And I think it is everyone's responsibility. And I'll talk a little bit about the burden of influenza today, and focusing on children and adults, although I'm obviously not an adult physician, and a bit about who really in those populations is at risk and what can we do about that. And I think Australia is in a lot of ways leading internationally in terms of flu surveillance, and therefore have a much greater opportunity to understand the benefits of vaccination. Talk a bit about updating us on where we're at with vaccine effectiveness, both in children and adults, through a number of studies that are happening in Australia, and to put it in context, talk a little bit about how well we're doing with coverage. And as I said, I think it's something that we can do a lot better, and I'll give some examples of that. Mention about vaccine safety in children in particular, because I think most people in this room would be aware of the problems that happened with the CSL flu vax in 2010 in young children. That was particularly an issue in WA, but did occur nationally. And then talk a little bit about where we might go with influenza vaccines that I think do hold some promises for improving the benefit. This is a graph that's highlighting the burden of influenza, and we can see that when we think about hospitalisations shown here in the white, that it is this typical U-shaped curve that we see in many infectious diseases. So the elderly, we know, are at risk for hospitalisation due to influenza, although they're not always notified, so it suggests we don't test old people quite as much. Whereas in young children, we have a degree of hospitalisations, but many more notifications. And I think this is mostly because the hospital coding issues, rather than necessarily most of the notifications are children who don't get admitted to hospital, because generally there's not a lot of testing that occurs outside the hospitals. There is some. But importantly to recognise that when we break down this under 4, who, as you can see, have the similar burden of disease to the elderly, it's really the youngest children, so the children under 2. And as you know, the influenza vaccine is not recommended for children under 6 months of age, so we're going to hear a lot about maternal immunisation. I'm not going to mention that again today, other than to say I think it's a great thing and you should do it. And it's a good area where we're not doing so well in terms of coverage, but also thinking that it's really the under 2s that bear the biggest burden of hospitalisation with influenza. So it's important. I think the other thing just to mention is that when we had the pandemic in 2009, it was really good for sort of trying to understand what the real burden of disease is, because everyone was getting tested for flu. And in fact, for young children, the graph looked very similar to this. Okay, so for young children under 5, every year is really a pandemic, because they haven't seen flu viruses circulating before, so they're just as susceptible. So it is a population we need to do something about. And I'll talk a little bit more about that. So Alan Cheng has been leading an initiative that really started out of the surveillance for the pandemic called FluCam, so looking for complications alert networks. So trying to understand, because it was clearly in the early days of the pandemic, we didn't really have a good handle on how sick are people generally when they get admitted with flu. And so trying to understand the severity of that pandemic was really important for those people involved. So this led to a network of, I think it's now almost 20 hospitals, started out with 12 and 15, including the Royal Adelaide here, that I think is a major contributor to the data. And they look at both the number of adults that have been admitted with influenza in the hospital, and then through a case control design also look at vaccine effectiveness, so how well is the vaccine working. And if you look at this data, that's 1,600 adults admitted into mostly teaching hospitals around Australia, so maybe slightly selective, that in fact adults over 65 are only about half of the admissions, which when I first saw this data I was a bit surprised. So I think what it tells us is that there's lots of adults being admitted, and most of them, you can see from here, are actually having medical comorbidities. And this is important. So there's a lot of adults being admitted to hospital with comorbidities who, as I'll show, are not vaccinated. So this is an opportunity missed. And if you look at it, not surprisingly, chronic lung disease is important, cardiac disease, diabetes, neurological disease, and so on. Importantly, also Indigenous adults. And I think it's really important to understand that it's not just Indigenous children, but also Indigenous adults who bear a very high burden of infectious diseases that we need to do something about. And so I think that, again, is everyone's responsibility to try and think about, is this patient in front of me getting the vaccines that they need? And that's both related to those factors that Tom was talking about, but also an increased prevalence of many of these medical conditions that puts them further at risk. And the other point to make about this data has been very useful to look at the different types of viruses and do they generally, there's a lot of discussion about which flu strain causes you to be sicker than another one. And so most people are aware that the typing on flu is based on those surface proteins, the hemagglutinin, which gives the H, and the neuraminidase, which gives the N when we talk about influenza A viruses. So generally the vaccines have an H3N2 strain and an H1N1 strain, and of course that was a new one in the pandemic, and it also has a B strain. And I'll talk a little bit later about those B strains because they're quite important, because there's really two distinct lineages within those B strains as well. And so there's now a number of vaccines that have been developed to cover both of those B strains rather than just trying to pick the one. And I'll talk about the implications of that. But the point of this graph is, and we can see here in the different colours that the flu Bs are in yellow, the H3N2s are shown in the red, and the H1N1s in the blue. And you can see that with the hatch bars are the ones who are admitted to ICU. So if we look at in this particular month, and this is 2013, we see we have actually quite a lot of flu B circulating, and then a proportion of those are admitted to hospital. And you can see these hatch bars, they vary a bit from week to week, but generally it doesn't really matter which flu strain you're talking about. They're all associated with intensive care unit admission, so very severe flu. And so this is an important message, that any flu strain in an individual, particularly those with at-risk medical conditions, can put you not only into hospital but into ICU. And the overall death rate in this cohort is roughly between 3 to 5%. It was, I think, 3.2%, and 1 in 10 actually having to be admitted to intensive care. So these are people who are really sick. So I think it's important, particularly when we're talking to adults who have at-risk medical conditions, that if you do get influenza, you may get very sick from it, you may get admitted to intensive care, and you may in fact die of it. So it's not just a trivial disease. So I think that's really important. And we saw in Helen's graph about the way GPs rate flu in terms of severity and the need for new vaccines, and kids and flu didn't rate very highly. It was down there with HPV for men. So I mean, I think that's really important for us to understand that flu is a serious disease. And again, when we look at hospitalisation rates, and this is from Rod Menzies and workers looking at notifications across Australia, you can see that for almost every age group, the number of, or the rates of influenza shown in Indigenous children and adults, shown here in yellow, is about twice or even greater than 3 or 4 times that of non-Indigenous. So this is a specific at-risk population who we need to be able to target with vaccination. And generally, again, we do fairly poorly. This was further borne out during the pandemic, when in fact all Indigenous adults presenting with respiratory illnesses were getting hospitalised, and this was from a particular study in the Northern Territory in the top end in Darwin, looking at admissions to hospital, where they found actually when they tested everyone, so not just the people they thought might have the flu, the risk was actually 12 times that of non-Indigenous adults. And they tended to be younger, more likely to live in remote communities, and had these additional risk factors such as smoking and alcohol use. Whereas the other comorbid medical conditions was pretty similar, apart from renal failure, which probably represents that increased proportion. And the other interesting fact about this study, looking at the clinical characteristics, is they tended to behave more like they had pneumonia. So they more likely had a secondary bacterial infection. And that goes with our understanding of overcrowding, high carriage rates of pneumococcus and Haemophilus and other bacteria associated with pneumonia. So not only you get the flu, you get the secondary bacterial pneumonia on top of it. So that's important for us to think about, this increased burden of disease and how we can keep these patients out of hospital. The other issue that we've also been studying here in WA is this issue of who actually gets tested. And so this is work from data linkage that Hannah Moore did during her PhD with us at the Telethon Kids. And she looked at what was your notification rate, your hospitalisation rate for influenza, depending on where you live. So if you lived in Perth versus living in rural areas versus living in remote parts of WA, of which there's quite a few. And you can see here that there is less testing if you look at just the non-Aboriginal children under 2. So generally, most paediatric centres will swab almost most children who come in, certainly at PMH, they all get swabbed for viruses, as well as taking blood cultures and so on for respiratory infections. But when you look at the Aboriginal population, when you start to get to the remote children being hospitalised, it's not these children aren't getting hospitalised, they're just getting hospitalised with pneumonia and not getting tested. So we're probably underestimating the true burden. So rather than that 2 times hospitalisation rates, it probably is closer to that 10 times that we saw during the pandemic. So I think it's important to recognise that particularly for Aboriginal children, that's an important cause of morbidity at all ages, that adults with comorbid conditions and those under 5 are at greatest risk. And it's pleasing to see that flu vaccination has now been recommended to be placed on the National Immunisation Program for Aboriginal children under 5. Okay, so that should be something that we're doing wherever we're seeing Aboriginal children in that age group. The question is, will we get very good coverage? And Tom talked about a real success with hepatitis A vaccine with the targeted program, but generally we've been not very good at targeting vaccination programs for Aboriginal children in other contexts. So it's going to be a lot of work has to be done in that space. And again, I don't think we can talk about the burden of infectious diseases without talking about the need to improve the living conditions and overcrowding and other risk factors that most of us accept for granted. But until we get those, we need to improve our vaccination rates in Indigenous populations. So I'm a paediatrician, so I'm more interested in children. So in WA, Chris Blythe has been trying to really drill down on saying, well, exactly in an average year, how much flu do we see? And so he's been looking over the last few years, excluding the pandemic, of all the, where we can quantify it, and again, it's not always easy, the actual burden, and it is a bit of an iceberg. If we're talking just about hospitalisations, we see there's 200 to 300 admissions a year with influenza in WA alone, so we'd expect almost similar, maybe a few less in South Australia. There's always a couple of deaths every year, they just don't get as notified. And what happened in 2007 was they tend to be clustered within a very short time frame, so within the same week, that drew the attention to them. And often it's due to secondary bacterial infection. A number of ICU admissions, a large number of emergency department visits with sick children, and certainly we've been doing a lot of surveillance within the emergency department confirming this large burden of disease of children who don't actually end up getting hospitalised but are sick enough to be packed out our emergency departments. Many more general practitioner visits and many more infections that actually don't even get to the GP, so managed by parents at home. So this is a major burden of disease, so up to 10% of all children are getting infected with flu each year. So this is something that is impacting on families and we just don't talk about enough. And clearly we also have some evidence that flu from children, not just preschool children but probably also school-age children, is important for circulation of influenza in the community. So it may be that we can impact on flu in those other older individuals with at-risk conditions by getting better vaccination of children. So there's a lot of flu around, so hopefully we take that as given. So does the vaccine work? And this is where some of the problems arise. So there's been a number of meta-analyses and Cochrane reviews, and generally this, for adults, this is the sort of number. So this is adults under 65 years of age. Vaccine effectiveness overall around 60%. So this is not 95% that we see with hepatitis A vaccine or 90% with Hib vaccine. This is considerably less. So this is a problem, I think, because you can't say you will not get influenza if you get vaccinated this year. And the other issue is actually this effectiveness varies from season to season and study to study. So you can see here in this plot comparing these different vaccine efficacy studies, and this is influenza proven laboratory confirmed illness, but not necessarily hospitalisations or presentations to the doctor, so active surveillance for influenza in adults. And you can see that between the studies there's significant variation, and this is the relative risk, so the further down you go this way, the more effective the vaccine is. Once you're about 1, the vaccine's not working at all. So this is studies that may occur when there's a mismatch between the vaccine and the circulating strain. So as the flu strains change, if there's a big change, then the vaccine's much less effective. So this is also a problem. So it will vary from year to year. So this is something we need to understand, and that's why these real-time studies like FluCan is really important for understanding what's going on and trying to give advice to people. But certainly you can say it's the only way we know of reducing your risk of influenza, other than things like smoking cessation, which is also important. So to try and generate real-time data, the FluCan have taken this approach that's a case control design, where you use the people who are tested for flu but are negative as the control to say, well, if you have the vaccine and what's your risk of not getting disease if being hospitalised with a respiratory illness versus those who have been hospitalised with influenza. And you would expect that the people who don't have flu will have higher vaccination rates if the vaccine is working. And so you can see here that in 2013, coverage was about 80% of those adults that are hospitalised with influenza in the over 65s are hospitalised with a respiratory illness. So that tells us we're getting good coverage in the over 65s, but under 65 it's only about 50%. And most of these are adults with at-risk conditions who should be provided by their GPs with flu vaccine. So we're not doing very well there. And when we compare the rates in the adults who had influenza, they were lower, the vaccination rates, and so we get this efficacy that again is around this 50% mark, varying from year to year, but certainly this is not something that, this is something that I think makes the case of selling influenza more difficult, but we don't have any other options. So do you give nothing? It's a safe vaccine, it's effective, it will have around 50% efficacy. Why wouldn't you give it? And it's funded. So really it's just the GPs and the specialists, I think, and I think this is one of the issues. I think there's sometimes a loss of responsibility between people who are unwell, who are often seen in hospital outpatients. The GPs might assume that the specialists are giving in hospital. Generally adult hospitals are pretty lousy at actually providing flu vaccine. It's difficult even to get their staff vaccinated. So I think this is important for general practice in particular to really take a lead in this area. The patients often think, well, if my specialist hasn't recommended it, why would I get it at the GP? So I think this is an area we can do much better in. Pleasingly, you're also less, if you are vaccinated and still get the flu, you're still less likely to end up in intensive care. So it probably modifies the severity of the illness. So in WA in 2007 we had these 3 cases that occurred in the first week in July on school holidays when I was off holidaying, and the minister said, well, we've got to do something about this. We can't have children dying of influenza. We've got vaccines, why aren't we using them? And so the WAVE study was born, which was really to evaluate the program, the decision by the minister to introduce flu vaccine for all children, provide it free for children from 6 months to 5 years of age, and we were asked to evaluate the effectiveness of it. So similarly to this case control design, so children who are eligible, so in the right age group who aren't immunocompromised, cases were those who were positive for the virus when tested, and the controls were children in the emergency department with respiratory illness and a fever who ended up testing negative on PCR for flu A or flu B. And there were some modifications as to make sure we actually took the swabs were taken properly, to look at those who got a virus isolated, so making sure that the swabs taken properly versus those who just didn't have flu vaccinated, but it actually didn't make a difference. Generally, you end up in an emergency department as a kid, you've got some sort of virus to be isolated. And these are the results, and you can see here that overall we had this is over 4 years of the study, so we didn't look at the pandemic when the seasonal vaccine obviously wasn't matched, but 2008, 2010, 11 and 12, and this was recently published in Paediatrics, we found a slightly higher estimate than seen in those hospitalised adults of around 65%, so again not 90%, but pleasingly, remembering that young children under 2 are most likely to have influenza and be hospitalised, the effectiveness in those young children was actually higher than in the older children. And we think this is probably because the match between the vaccine and the strain circulating, and this is the first time these children have come across it, is better for the under 2s because it's the first time they've been vaccinated, as opposed to 3, 4 and 5-year-olds who have probably seen either the vaccine before or the previous virus, and that may somehow sort of start to hone your immunity towards that original strain you come in contact with, and that's something that's called the original antigenic sin, and it may be important. And again, we found that the influenza A had slightly higher efficacy than the flu B, which mostly were related to mismatch between the vaccine and the circulating B strain, particularly in 2008, but also in subsequent years, so that the strain in the vaccine wasn't a good match for the strain circulating in WA. So what can we do to decrease the disease burden that I've just demonstrated? So certainly we can improve vaccination rates, and this again is from that publication by Rob Menzies at the NCRS in Communicable Disease Intelligence, looking at overall in the population. If you look at the 65 and above in the non-Indigenous here, we're getting over 70%, so that's in keeping with the general estimate, so it's somewhere between 70 and 75%, but in the in the 50 to 64-year-olds, then we get much less coverage, and a similar story in the Indigenous population. Good at the targeted age program for the over 65s, not so good for those who have at-risk medical conditions and are younger. So there's a lot of work to do, I think, there. And paediatricians, I'm sad to say, are actually worse than the adult physicians. And this was during the pandemic. We again recruited a cohort in a number of studies, including here in Adelaide, looking at children being admitted with influenza, with the pandemic influenza, so we wouldn't have expected vaccination to make a difference to their risk of being admitted, and we found that about half the children admitted, so as opposed to 75 to 80% of adults with comorbid conditions, only about 50%, and these are the sorts of conditions they're admitted with. But look at the coverage here at the bottom. Only 10% of those children had been vaccinated. So all these at-risk children are generally not vaccinated, and in all the studies that have been done, the background rate in children with cystic fibrosis or cardiac disease or cerebral palsy is similar to that in the general population. So and again, this is another example of where I think there's a breakdown between the specialists and the GPs of actually not saying, look, have you had the vaccine? If you haven't, here it is. And in WA, we were able to improve this with our general program. So when we start to recommend it for everyone, coverage rates go up. But as soon as coverage rates in the general population come down with concerns regarding side effects, so do the rates in those at-risk children. So we don't seem to be able to get that message across that there's a particular reason, because you've got this condition, that you should get hospitalised for immunised for flu. As I said, the issue in WA has really been about vaccine effectiveness, and certainly in 2010 this was a particularly harrowing time for somebody who had been saying what a wonderful thing it was to get flu vaccine, to suddenly get all these calls again when I'm on holiday during Easter holidays this time at Rottnest, getting all these calls from doctors saying, oh look, my child's had flu vaccine, they had a febrile convulsion 24 hours later, do you think I should have the second dose? And I said, oh, that's really rare, but you know, it's probably incidental, but yes, I'd certainly recommend it. It's nothing to do with the vaccine. After about 3 of these calls, I started to get that's a bit odd. So I rang when I got back to work on the Monday. We started to look at the emergency department, and people said, oh yeah, actually I have seen quite a few kids coming in with febrile convulsions. So when we started to look at it systematically, it was quite clear that there was an association that children were coming in with these high fevers within 6 to 12 hours of receiving the flu vaccine and not having any preceding respiratory illness. So they didn't have that sort of typical viral history, often vomiting as well. And the parents did say, when you spoke to those kids who actually got hospitalised, and there was a number of those, look, they were perfectly well, and suddenly they started having rigors and chills and having febrile convulsions, and a number of them got treated as sepsis, so they actually looked pretty sick. So what went wrong? Well, it was actually related to the way CSL was making, and had been actually making flu vaccine this way for a number of years, and the detergents that they used and the strength of those detergents meant that there was more residual parts of the flu virus that were left in the vaccine compared to other manufacturing processes. But this only really became an issue when they changed the strains that were in that particular vaccine, and particularly the B strain, but probably also the pandemic strain, for various reasons didn't split as well. And so both CSL and ourselves published that you could show that if you put the CSL flu vaccine with immune cells from children, so where they'd been taken off the children, you could actually elicit a response that's very similar to flu, with very high levels of interferons that drive this fever. And so it was one of those cases where it was actually the flu vaccine causing the flu, and everyone talks about this, but this was a case where it was actually true. So I think, so is the vaccine safe? Well, we know that millions of flu vaccines made by other companies using different processes have been distributed over the last 15 to 20 years with no significant safety concerns, even when people have gone to look back at it. Prior to this issue in 2010, 40% of under 5s in WA had been vaccinated without any significant problems, and again we confirmed that. That since then we've been looking very closely both in the Northern Hemisphere but also here in Australia, and in Australia we haven't had any febrile convulsions with the same sort of time frame as was occurring in 2010, other than those children who accidentally have received flu vax subsequent to that. So in WA we haven't had any flu vaccine attributable febrile convulsions since 2010. So, and in fact now we've what became clear though was we needed to restore the public confidence. And as part of the investigation and reports, it was clear that the public weren't aware that actually every time you change the strains in a flu vaccine, you don't actually go through clinical trials in all the different populations for which the vaccine is recommended in. So there's small lot release studies in adults. It's mostly about immunogenicity, it's not about safety, but there's no studies in children. And part of it's the time frame's too short. So you don't actually have enough time from when the decision is made to, this is the strains we're going to use in the vaccine this year, to make the lots, which takes several months, then to test it before the vaccine can, so it's simply not able to be done. So we needed to design some sort of way of looking quickly at vaccine safety. So we came up with the FAST study. So the sort of influenza active surveillance, follow-up and active surveillance of trivalent influenza vaccine, so the FAST study. And it was pretty simple. All we did was that we, any children receiving the influenza vaccine in the children's hospital or in our major immunisation clinic received a phone call from our research staff several days later to say, look, had you had any problems following the vaccine? And we'd actually done this in 2010 after flu vax. And you can see here in blue that more than 50% of parents in those original surveys, when we were trying to work out which vaccine was responsible, said, oh yeah, my child had a really high fever. It started the day after the day of the vaccination or that evening. And since then, in 2011, 12, 2013, we haven't had anything, and again in 2014, where this has now become a national surveillance system, we have seen very low rates of fever of the order that you would see with any other inactivated vaccine, so less than 10%. And importantly, we don't see those other symptoms of rigors, vomiting, fatigue that we saw, and importantly, no febrile convulsions have been occurred in those immediately following vaccination. Febrile convulsions still occur in vaccinated children, but they just don't occur in that sort of very short 12-hour window. So I think this is reassuring, and now this is going to be an ongoing surveillance mechanism for reassuring parents around safety. And the idea is to have it in real time so people can actually look to say, look, how many children have been vaccinated so far? Have there been any problems? There's still some issues to work around that, but I think we're really improving that. Now we're looking to use SMS technology, so we don't actually have to catch somebody on the phone. They can just be SMS'd, get back to us straight away, and that will be, I think, a much more efficient way of being able to confirm vaccine safety. And I think that's going to be something we're going to see a lot more of. So I still think for paediatric flu vaccine, we have to concentrate on those with at-risk conditions. So that's an important thing. We need to be able to know what the coverage is, and again, we need to, sometimes there's software glitches with GP practice software, which means things change and they get updated. It doesn't always capture the flu vaccine coverage as well as it might, but it's really important for the people here who are working general practices to make sure it's entered onto the system and it actually gets recorded. We need to be able to monitor safety in real time, particularly when we change strains in the vaccine. We need to be able to demonstrate effectiveness. We really need to have this better surveillance generally, I think, and there's been a number of initiatives that have been undertaken in WA following the SafeVic model, where we sort of have and here in South Australia, it's a much more open-ended, where people can ring in and say, look, I've had a problem with the vaccine, and people follow it up. And I think that's really important for providing reassurance to people, and parents actually are very pleased that somebody's taking notice of the fact that their child's had a problem. They're not so worried about trying to sort out what their child's problem is unless they need to be revaccinated. We need to be able to give real-time estimates of how well the vaccine's working, so I think the FluCan model or the WAVE study are good examples of that. In terms of getting it on the national program, that's really about cost effectiveness. And Helen said you can have a vaccine that parents want, is licensed, but to get on our national program it has to be cost effective. So we have to have good data supporting those sorts of what's the burden of influenza that actually the government have to pay for, not parents. You miss time off work or has issues around quality of life. They're not so important unless they impact on government spend. And obviously we're going to hear more about maternal immunisation in pregnancy, so I won't talk about that for preventing early flu. So just in the last couple of minutes, I just wanted to talk about what's on the horizon because I think it's important. Now, I've talked a little bit about this issue with B strains. So there's these two different lineages that co-circulate around the world, and you can see here that this is looking at a number of countries across Asia, and the percentages of those that belong to one of these strains, so the Victoria. So you can see in 2008 it was about 8% here, but in Australia, New Zealand, in China and Japan and Malaysia and the Philippines, but in Australia it was almost half or three quarters. So clearly different lineages circulating in different hemispheres within the same year, and again it varies. It's a bit more similar here, again some differences here between the Philippines, say, and Australia. And even sometimes differences between Australia and New Zealand. So in 2012 there were significant differences. So it's very hard to predict any particular country which strain's going to be circulating. And you can see different countries have been different in terms of their ability to match the vaccine with the strain circulating for the B strain. So this is just about the B strain. So you can see there's been a good match as well, almost never in China. In the Philippines, Australia seems to be doing better, maybe because we have representatives on the WHO, we have better surveillance, so they're more likely to take notice of what we think is going to be circulating. But certainly in 2008 and 2009 there was some mismatches in those circulating. So we don't always get it right, and some people have suggested it's about 50-50, so we may as well flip the coin. So what can we do about that? Well, there are now quadrivalent vaccines, so they have the H3 strain, the H1 strain, and then one of each of those B strains. And again, they still have to select these B strains depending on what's circulating, because even within each of those lineages, they will have some subtle differences. So because flu is very good at changing, and that's part of the problem, that you have to change the vaccination every year. And I think there's no real strain vaccines that we often hear about these breakthroughs, but I still think there's a long way to go before we'll have a vaccine that will protect against all flu strains. The good thing is, though, these quadrivalent vaccines work well, and this is a study that was recently published looking at how well the vaccine was responded in children, and you can see, that for both the B strains, 1 month after the vaccination compared to baseline, this was a placebo-controlled study, so we see some increases in antibody over the flu season, presumably a few kids being exposed to those strains. But you see that for both the Victoria and the Yamagata lineage, you get very good antibody responses after a single dose, and actually they persisted for the duration of the study, so the 6 months of the flu season. So actually getting pretty good protection. So I think, and this is consistent with most of the paediatric studies, that actually young children do respond well to influenza vaccines. And of course we also get high titers to the A strains contained within the vaccine. But importantly, when they looked at effectiveness, the attack rate in the vaccinated group was about half that, or less than half that in the control group. So the overall protective efficacy of this quadrivalent vaccine was again around 60%, but they were also able to look at more moderate to severe flu. So this was looking at a series of criteria, which are mostly around, did they have evidence of pneumonia or lower respiratory tract signs, so wheezing or ending up in hospital or having very high fevers and requiring medical attention. You got a greater protection against the moderate severe flu and protection against both the A and the B strains. But during this study, unfortunately, there was only one B strain that was really circulating, and again, we saw around this 50% effectiveness. So even though we're getting better coverage, we're still getting a similar effectiveness for each strain of the vaccine. So it's not clear that it'll actually have a huge impact. But importantly, there's no differences either in adults or in children in terms of the reactogenicity rates of having this additional B strain in the vaccine. So it appears to be safe. And in fact, it looks as though most vaccine manufacturers are going to completely change over to these quadrivalent vaccines. So these are now licensed in Australia and may well be being used and eventually will replace the trivalent vaccine. Now currently CSL doesn't have a licensed quadrivalent vaccine, and that supplies about 2/3 of the vaccines that are in the market. So it's likely that it'll still mostly be trivalent vaccines, but it may be that for the private market in particular that quadrivalent vaccines might be suggested. The question is how much more will they cost, and that's still to be determined. And of course this will determine whether or not they end up on the schedule. But it probably won't cost a lot more to make the vaccine, but it may cost more to sell it. But I think this is the real answer. So the United States have been, for some time now, have had a live attenuated intranasal flu vaccine that's licensed for children over 2 years of age and for younger adults, and has much higher efficacy. So rather than 50%, it's up above 85%. Also doesn't need to be given as an injection. So it's quite popular and actually is being introduced in the UK for children where they're vaccinating young children over 2, but also school-aged children with this vaccine. So it's quite amenable to mass vaccination in schools. Unfortunately, the company that makes it haven't been able to make it for the Southern Hemisphere, one because they haven't perceived there's a big enough market, but now as large countries in South America are starting to use more flu vaccine, they're now starting to consider this for Australia. And I think this would be a great breakthrough in terms of a more effective flu vaccine that we can give to young children, and actually almost seems to last 2 years in terms of the duration of protection. So it gives much better protection than the trivalent vaccine alone. Another alternative is an adjuvanted influenza vaccine. So this is again from an older study in Europe where they looked at an adjuvanted fluad, so a vaccine that's licensed in Australia for the elderly to give an improved immune response, because you know the elderly don't respond as well. But in children you get this significantly higher vaccine of effectiveness, so again around 90%. Unfortunately, this vaccine's not licensed in Australia or Europe, and there's more safety data to be collected, but I think this is another option potentially. So finally, I think hopefully you would agree, flu continues to be a major vaccine preventable disease burden in children and adults. I think the pandemic has told us a lot about other groups that perhaps we hadn't thought about, like the pregnant mums, like obese adults. But I think there's also an important need to make sure that we can demonstrate how much flu is occurring still. We do prevent morbidity with the available vaccines. They could be improved with new delivery systems or adjuvants. But I think in the interim it's the responsibility of everyone in this room to make sure that everyone who we come into contact with through the healthcare system is aware of their need to get vaccinated each year, particularly those who have at-risk medical conditions. So I'm happy to take any questions, and thank you for your attention.
About the delivery system of Intravest, what about nanotechnology and the nutritional view of having bananas with vaccine in it?
Yeah, okay, so flu mist actually is the name, but the nanotech, I think probably the most exciting development is actually an Australian one, which is this patch technology where you actually can load the antigen onto tiny spikes that just get into the outer layer of the skin that actually immunologically is the best place to stick a vaccine. Subcutaneous and interfat's no good, as Helen was showing. Muscle's pretty good, but actually intradermal is better. We do have an intradermal flu vaccine that's currently registered for adults that actually doesn't seem to work that much better. So I think there's still some understanding of the best way to deliver it. So there is some progress, I think, in that nanopatch technology, but I think there's still a way to go. I mean, the advantage also, you don't need as much vaccine antigen on those, so that is something possible. But I think that's a way off, so we're talking 5 to 10 years, I would say, before you have it in your general practice. Plant vaccines is a really interesting one. Unfortunately, as attractive as it sounds, the studies have really showed that you can use vegetables to generate antigens, but giving them orally is not a great way. So we haven't, and I think it's, so they've talked about actually growing tomatoes that have hepatitis B or bananas, but then you dehydrate them, and it's a cheaper way to make it than trying to make it in a batch and growing up bacteria. But I think that's probably not going to produce what we hoped it would. So that's really hasn't gone anywhere in 10 years, I don't think.
Hello there. I was just wondering about the post-vaccination reaction with the nasal sprays.
So the main issue, in fact, has been, the main safety issue has been around wheezing in younger children, and you'll notice that I said it's from 2 years of age, because in the studies of those kids under 2, there was a significantly greater proportion in the vaccinated group who developed wheezing post-vaccination. So we know generally with the inactivated vaccines that doesn't trigger wheezing in asthmatics, but it did in those young children. So it seemed in predisposed children that you might actually have a small proportion who wheeze. It's probably, in fact, the studies show that there was still of overall benefit, so you're more likely to have a wheezing illness with influenza in the unvaccinated group, but the company has chosen not to register it because of that particular reason. You can get some upper respiratory tract symptoms as well, and so that probably means that for very young babies, so under 6 months, it's probably not a goer. Interestingly, in adults, that this very high efficacy that we saw in young children wasn't quite the same. So it came back towards those inactivated vaccines. And again, that probably gets back to this. You want to have a really good vaccine the first time you see flu, if you're going to do it. And so, but otherwise, there's been no safety concerns. So if it was available, it'd certainly be a vaccine that we'd specifically be interested in, but particularly for children, I think.
Hi, I was doing my pre-season flu vaccine orders a couple of weeks ago, and I had the choice of the trivalent or the quadrivalent vaccines, and the quadrivalent was more expensive.
Yeah.
So it was that decision of what do we get in our practice, and how do we have that discussion with people about what's going to be more effective for them,
Yeah.
especially when price is going to be an issue because we're going to sell them at different prices.
Yeah. It's all about the price you charge, or the price you're charged. So I mean, I think if all things were being equal, it's a bit like having a 10-valent pneumococcal vaccine and a 13-valent. We in Australia have gone to a 13-valent vaccine because it gives you an extra three types. This will give you an extra B strain. I think the demonstrated superiority is still so hard evidence, so that randomised control showing that you're getting better protection against both B strains compared to just having one B strain is still missing, I think. But I think it's one of those things that we really do need to evaluate, because you saw from that graph that I showed of those hospitalised adults that a number of those adults with B disease were getting severe disease. So I guess if you can afford it, I'd say, look, this will give you extra coverage. But depending on your markup and the markup of the wholesale company, I think it's a difficult choice, and it will depend on what they can afford. So certainly I wouldn't say everyone has to pay for it. It's a relative, because I think the level of evidence is not there yet. But all things being equal, I would prefer to go with a quadrivalent vaccine. So in WA, for instance, for the under 5 program, I think we would prefer a quadrivalent vaccine than a trivalent. The company's actually saying that in the long run you won't have that choice. They will only produce a quadrivalent vaccine, and so the question in somewhere like Australia is, will we pay for it, or will they reduce the cost so that it's more or less the same? But I think they're waiting on some of these sorts of effectiveness studies to say that. But it's a really good issue. So generally I'd say, yes, have it in so that people can have the option, like any vaccine, but it won't be funded on the national program, for instance. So then it might be about, is it going to be too confusing, and are we going to be giving more expensive vaccines out when we've got free ones in the fridge because everyone says, oh yeah, I want the 4-in-1. And I suspect that might be an issue for leakage and those sorts of things. So your business manager will probably say, no, we'll just go for the trivalent vaccine. But I do think it's something that we should be aware of and preferably give people choice. I mean, I think that issue of choice is really important. I think generally as doctors and nurses and health professionals, we sort of automatically assume we know what the patient's thinking. And I think this idea of getting good informed consent, and if you're ordering vaccine, you should have had some good quality information about how do you make that choice. How do you decide what to buy? And I think that's something in Australia we can do better about getting information in a way that people will actually use it. Why do we not have a 30-second or 2-minute video clip rather than a 2-page information sheet in small print where we're reading? So that's the sort of way I think we need to get that across. But I think as health professionals we need to be across the evidence, and from my perspective I think there's still some question marks. So if you're canny with your money, then maybe wait and see what happens. But if you want to have choice and you've got a well-heeled population, then I'd have a quadrivalent vaccine in the fridge, because that might be the marketing advantage for your practice over another practice.
So talking about adult immunisation with the flu, we know that the vaccine's not as efficacious as we want, and we're talking about delivery systems. When we're delivering it to adults, we're delivering it to a number of these patients, and we're going into the adipose tissue because the needles, they come pre-glycerins and the needles are really quite short.
Yeah.
Is there anything happening about increasing the length of that needle so that we've got a better efficacy on the vaccine? It's a big problem for us.
Yeah, that's a good question. Why did not the NHMRC fund Helen Marshall's study that was specifically looking at this? Yeah. Look, I think this is really important. So I think as our population changes and ages and gets fatter, we need to adapt our vaccines likewise. So there's actually relatively little information about this. So if any funders in this room, this is a study we need to do. And I think the vaccine companies need to look at it more seriously. So you have a choice. This is the one.
Our chair has the final word.
Sorry, I was just saying, I do think it's a really important issue, and the fact that we have a fixed 16mm needle on a syringe that you cannot, we have tried, we've spoken to companies in Australia, are they able to provide it in any other way, just even for our study, just to see whether there is a difference in where the vaccine ends up. We know, using ultrasound, that it doesn't get to the muscle in obese people with a high BMI, over 25, which is not even that high. So I think it's a really important question. We are doing this study to try and address this in pregnant women, but we also originally had a grant in around adolescents as well, receiving the children. That's really important. So I can't see a way forward at the moment, but I think if we can provide some evidence, then perhaps that will move policy forward.